All right. All right. Good afternoon, everybody. I'm going to be presenting culture negative endocarditis with a little bit of South African data that we have recently had the privilege of having in the last year or so. Okay, so in terms of the definition, infective endocarditis is defined by the infection of native or prosthetic heart valves, the endocardial surface, or any cardiac prosthetic device. The one-year mortality is said to be as high as 30% in both the developing and the developed world. In terms of the demographics in the developed world, we usually see it in older patients with underlying degenerative valvulopathy. And the usual culprit here is virulent staphylococcal infection. And this is because of the increase in life expectancy, perhaps also a reduction in the prevalence of rheumatic heart disease, an increased availability of antibiotics, increased admission to healthcare facilities, and lastly, the advent of modern cardiology, where device therapy plays quite a critical role. It's actually reported that up to 10% of infective endocarditis currently is associated with cardiac implantable electronic devices. In the developed world, we see it more in younger patients with underlying rheumatic heart disease, and here the culprit is often streptococcal species. Staphylococci we know are usually associated with healthcare contact and invasive procedures, and they have actually overtaken streptococci as the commonest organism. Streptococcal infective endocarditis caused by the oral viridans group remains the most common in low to middle income countries and has been reported as the commonest cause in South African literature in the past. In South Africa, it's still strongly associated with rheumatic heart disease. So we thus see a bit of a younger population with underlying RHD. There was a 2003 Cape Town study. It was actually a 3-year prospective study in Tygerberg that included about 92 patients. And here the median range of, or the median age was actually found to be 37.7 years. And 72% of these patients with native valve endocarditis had underlying rheumatic heart disease. Then there's another Echo in Africa study by the British Echocardiographic Association. And this was basically a study that screened 6,000 secondary school learners. And 20 per thousand were actually found to have borderline to definite criteria for rheumatic heart disease as per the World Health Federation criteria. And this is just showing, what a burden of undiagnosed rheumatic heart disease we actually have in our population. Lastly, there's also an increasing burden of IV drug use, especially Nyaupe use, as was described by Meal et al. There was a case series in Chris Hani Baragwanath Hospital for the period of December 2014 to 2017. And up to 68 cases were found, attributed to IV drug use. And a third of these cases were interestingly culture negative. In terms of the worldwide prevalence of blood culture negative endocarditis, it's shown to be anywhere between 10 and 30%. Again, that prospective study from Cape Town in 2003 showed that quite a high proportion of culture negative endocarditis, more than 50% in that cohort. And then another more recent study, which we will discuss a little bit more in detail a little later, where there were 2 arms, a prospective and a retrospective arm, again showing quite high incidences of culture negative endocarditis, 43 and 63% respectively. So why is this? Do we have local unidentified pathogens? Are our blood sampling techniques poor? Are we prescribing antibiotics before actually sampling the blood? Or is there a lack of knowledge and a lack of use of the PCR techniques that we have available for us? In terms of the challenges with culture negative endocarditis, it has been shown that it has a higher mortality and a higher rate of surgical complications. The other issues is we often need to provide empiric antimicrobial therapy for the likely pathogens in our setting. But these may pose issues with toxic side effects, particularly with aminoglycosides that we use as empiric therapy. Also, with regards to the diagnostic techniques to define fastidious or usual pathogens, they're not really available at most laboratories and require quite a considerable time for completion and testing of the specimens, and they often have to be sent to a reference lab. This was a study from the European Heart Journal. It was the Euro-Endo registry that was comparing culture negative versus culture positive endocarditis. I think just a little over 3,000 patients were actually enrolled in this study. And basically why I included it is just to show you that there has been confirmation of a higher long-term mortality in patients with culture negative endocarditis compared with that of culture positive endocarditis. But this difference, however, was present in patients receiving medical therapy alone and not in those who underwent surgery. In terms of diagnosing endocarditis, so this slide just shows us a brief history of the diagnostic criteria that we were using. So in the 80s, we used the Beth Israel criteria, and there were a few issues here. There was no inclusion of any echocardiographic findings, no inclusion of isolation of typical infective endocarditis pathogens, and no inclusion for IV drug use as a risk factor. In 1994, the Duke criteria was created, and it was modeled after the Jones criteria for rheumatic fever. In 2000, the Duke criteria was modified, and then just a few things were actually changed, and one of them was Staph aureus bacteremia was included as a major criteria, and Q fever, Cocciella serology was also included as a major criteria at this point in time. Then in 2015, Duke criteria was modified again, and the ESC actually added CT findings with or without FDG PET CT findings consistent with infective endocarditis. Now the question is, do we need another? Do we need an addition to the modified Duke criteria? And we probably do, and we'll see this a little later. So just refreshing your memory with the modified Duke criteria. So definite infective endocarditis needs to meet either pathological criteria or clinical criteria. The pathological criteria is where microorganisms from culture, histopathologic examination of a vegetation or a vegetation that is embolized, or even an intracardiac abscess specimen, or pathologic lesions where vegetation or an intracardiac abscess is confirmed by histologic examination showing active infective endocarditis. In terms of the clinical criteria, one needs 2 major, or 1 major criterion with 3 minor, or 5 minor criteria. In terms of the major criteria, so blood culture positive criteria for IE is the presence of typical microorganisms consistent with IE from 2 separate cultures. And these typical microorganisms have been documented as, the viridans streptococci, Streptococcus bovis, the Hasek group, Staphylococcus aureus. And meeting the criteria below is at least 2 positive cultures that are drawn more than 12 hours apart. The second criteria would be community-acquired enterococci in the absence of a primary focus, or lastly, microorganisms consistent with IE from persistently positive cultures. In terms of evidence of endocardial involvement, you need echocardiogram evidence of infective endocarditis, either transesophageal for prosthetic valve or a transthoracic echocardiogram. And the echo findings are defined by an oscillating intracardiac mass on valve or supporting structures in the path of regurgitant jets, or also on an implanted material in the absence of an alternate anatomic explanation. Secondly, abnormal activity around the site of the prosthetic valve implantation that can be detected by an FDG PET CT or radio-labeled leukocytes on a SPECT. And then lastly, definite paravalvular lesions seen on cardiac CT. In terms of the minor criteria, so the first one is predisposing heart condition or intravenous drug use, a fever more than 38 degrees, the presence of vascular phenomena, which includes major arterial emboli, septic pulmonary infarcts, the presence of mycotic aneurysms, intracranial hemorrhage, conjunctival hemorrhage, and Janeway lesions. The presence of immunologic phenomena, which includes glomerular nephritis, ocular nodes, Roth spots, and rheumatoid factor positivity. And then lastly, microbiological evidence, which is a positive blood culture not meeting the major criteria. So this is actually an accepted manuscript from the International Society for Cardiovascular Infectious Diseases. So this is the proposed update to the modified due criteria. So it's been dubbed the 2023 due criteria. And here quite a few things have actually changed, but I just wanted to draw your attention to the pathologic criteria now that includes diagnosis by PCR or metagenomic next generation sequencing. The typical organisms are now to include E. faecalis, all the streptococci except strep pneumoniae and pyogenes, A. biotrophia species, Gemelli species, and typical organisms for prosthetic material have now been included, as well as an IFA IgG titer of more than 1:800 for both Bartonella henselae and Bartonella pantana. So there's some changes to the minor criteria as well that's been proposed. And again, PCR and metagenomic next generation sequencing for typical pathogens have been added here. So what are the causes of culture-negative endocarditis? So the first, most important perhaps, is prior administration of antibiotics. So cultures must be drawn before administering antibiotics to improve pathogen identification. It seems quite obvious, but exactly how much of an impact does this have? So a German prospective study in 2019 actually looked at the impact of antibiotic administration on blood positivity in sepsis. And blood culture positivity was 50.6% among patients who did not receive antibiotics, and was only 27% in patients who had already received antibiotics, showing quite a big or significant difference. Second issue is possibly inadequate microbiological techniques, and problems may actually arise from inoculation of the culture bottle where an inadequate volume of blood is inoculated. So ideally 10 moles in each bottle, both aerobic and anaerobic, should be collected. And blood is preferably collected from peripheral sites, avoiding femoral site punctures, and should not be drawn from existing catheter sites. Blood should ideally be at room temperature for maximum of 2 hours and then be transported immediately to the lab for processing, which we often run into difficulty with in our settings. So other causes include right-sided endocarditis. It's commonly associated with IV drug use, central venous catheter insertions, and intracardiac devices. So IE related to peripheral venous lines are actually uncommon. However, local cellulitis and the use of infusion pumps and insertion of a catheter into the lower extremities have been shown to be independent risk factors for right-sided IE. Lower incidence of right-sided IE can be explained by lower prevalence of pathological conditions affecting the right-sided valves, including congenital malformations, differences in the properties of the vascularity of the right-sided endothelium, as well as lower pressure gradients and jet velocities across right-sided valves, and lower right-sided wall stress and reduced oxygen content of venous blood. Other causes for culture-negative endocarditis include uremia, mural infective endocarditis that is associated with ventricular septal defects, post-myocardial infarction, thrombi, and pacemaker wire infection. Also included a slow growth of fastidious organisms, anaerobes like Haemophilus, Actinobacillus, Cardiobacterium, Abiotrophia, Granulocytella, and Brucella. Fungal infective endocarditis, particularly Aspergillus fumigatus and Candida albicans, commonly implicated. And then infective endocarditis caused by obligate intracellular pathogens like chlamydia, Cocciella, and Trichoderma whipplei. Non-infective causes, or otherwise known as non-bacterial thrombotic endocarditis, NBTE, or merantic endocarditis, is characterized by the presence of sterile vegetations in the heart valves and is associated with hypercoagulable states. So cancers, most commonly mucin-producing adenocarcinomas, are implicated, often pancreatic. as well as autoimmune diseases such as lupus, like we see with Libman-Sachs endocarditis. So trauma and catheter insertions may also be associated with non-infective endocarditis. And lastly, is it the correct diagnosis? In terms of non-culture-based diagnostic techniques, we have access to serology, serology for Bartonella, Brucella, Cocciella, Legionella, and Mycoplasma, although these are outsourced to private labs in the state facilities. They are inexpensive, and the majority of the identified pathogens can be identified using these techniques. In terms of histopathology, it offers a definite diagnosis, and we're able to differentiate non-infective from infective causes. In terms of PCR, again, we're able to detect multiple organisms. It's quite rapid. We have access to a 16S rRNR pan-bacterial PCR, and 18S rRNR for fungal PCR is available. In terms of metagenomic next generation sequencing, it's quite a new technique that's been studied further. Sometimes called shotgun sequencing, is actually the running of all the nucleic acids in a sample and then assigning these to the reference genomes to understand which microbes are present and in what proportions. The issues here is there are no current protocols for sample processing, for sequencing and bioinformatics analysis, and it's quite an expensive technique. So this is actually the European Society of Cardiology algorithm for blood culture negative endocarditis, where it suggested that we actually start off with an adequate patient history, where we try to elicit any exposure to livestock, to cats, to any birds, which will then be followed by serology for Cocciella, Bartonella, Brucella, Mycoplasma, and Aspergillus. So if these come back negative, it's suggested that blood PCR assays should be performed for Trichomonas Whippley, Bartonella, Candida, and Aspergillus. If we are fortunate enough to get a tissue culture, a histology, then we should perform tissue culture on the histological specimen as well as a PCR. And this is obviously if the patient is requiring surgical intervention. And then lastly, if all our workup has come back negative, it's suggested that we work up for non-infective causes. So we should look for SLE or antiphospholipid antibody syndrome by doing an anti-nuclear antibody, anti-cardiolipin antibody, beta-2 glycoprotein, or lupus anticoagulant. And if there's prosthetic valve or bioprosthetic valve endocarditis, perhaps an anti-pork antibody should be done. So this protocol was actually used for pathogen identification of blood culture negative endocarditis in the prospective cohort in the Western Cape study that we spoke about earlier. And this protocol basically, what they did was they had done both aerobic and anaerobic cultures. And if they were negative at 5 days, they were said to be a culture negative endocarditis. And the entire workup was done, including serology for Bartonella, Brucella, Cocciella, Legionella, and Mycoplasma, and ANA and ACLA. Blood was also sent off for mycobacterial cultures, and then a broad range PCR sequencing was performed. If patients had surgery, broad-based PCR sequencing was done on the valve tissue, as well as bacterial and fungal culture and histopathologic analysis. So this was the algorithm that the study has used. We'll discuss this now in more detail. So basically what this was a prospective study using the set protocol that we've just seen now for organism detection, and they compared this to a retrospective cohort. And basically what they've showed is that no organism was detected in 57% in the retrospective cohort versus a much smaller number, 13.8% in the prospective cohort. Also showing that inpatient mortality for culture negative endocarditis versus culture positive endocarditis being quite similar in both groups, but mortality was higher. Sorry, inpatient mortality for culture negative and culture positive was similar, but culture negative mortality was quite higher in the retrospective group. So this is the pie chart taken from this study, in which we can see the causes for blood culture negative endocarditis. So we can see quite a high number of serology came back positive for Bartonella. Again, 32% where no cause was identified. And then also interestingly, which is not very well documented in the literature, but Mycobacterium tuberculosis was responsible for 7% in this cohort. And then another smaller number, 4% were actually said to be non-infective endocarditis. Then apologies for this busy slide, but I just actually wanted to compare these two pie charts that are also taken from the study. So the left pie chart is showing causes for blood culture positive endocarditis. And like we'd expect, Staphylococcus aureus is responsible for the majority of cases, accounting for 46%, followed by the viridans group Streptococci, and then the other pathogens accounting for smaller numbers. Now, the pie chart on the right is actually showing the all causes of infective endocarditis in both culture positive and the culture negative group after using that set protocol. And now we can see that Staphylococcus aureus has actually come down as the lead, still the leading cause, but now at 26%, with viridans Streptococci down to 16%, and Bartonella species actually accounting for as much as 20% of this cohort. Okay, and then I just want to discuss quite briefly these pathogens, Bartonella, Brucella, Cocciella. So we'll first talk a little bit about Bartonella. So Bartonella is a small facultative intracellular gram-negative bacillus, and the two commonly implicated species are the Bartonella henselae and Bartonella quintana. So henselae is usually resulting from exposure to cats or cat fleas, and quintana from louse infestation, and commonly seen in homelessness and patients with alcohol abuse. In terms of the clinical presentation for IE, they usually present with fever, in-heart failure, with quite large vegetations and significant valve destruction. We can use serological techniques to diagnose it. We can use blood culture, although they're very, very slow growing. The organism produces very little CO2 to trigger the back tick system, and it's best grown on a Columbia rabbit or BHI agar. We can also culture the tissue if we were fortunate enough to get tissue, and we can do PCR techniques. In terms of the treatment for Bartonella, doxycycline and gentamicin is the recommended antibiotic. So Brucella is a small facultative intracellular gram-negative bacillus. Brucella melitensis is the most common cause of IE. And it's usually results following ingestion of unpasteurized milk or dairy products or livestock contact. In terms of the clinical presentation for IE, they usually present with fever. They may or may not have hepatosplenomegaly. They may also have large vegetation seen on echocardiogram. In terms of the diagnosis, again, we have access to serology. We may be able to culture, although they're very, very slow growing, about 6 weeks to grow on culture. We may be able to do a tissue culture, even a PCR. And in terms of our treatment options, again, we have doxycycline and gentamicin or rifampin as a recommended treatment option. And Cocciella is an obligate intracellular pathogen, and this usually follows a history of exposure to livestock. It's usually shed in urine, feces, milk, and in birth products. It actually lives in the phagolysosome of infected cell, and the highest bacterial loads are often seen in the placenta. In clinical presentation of IE, they present with a low-grade fever. They may or may not have hepatosplenomegaly. They may present with heart failure, with immunological phenomena, and patients often have underlying valvulopathy, are immunocompromised, or have prosthetic valves. The diagnosis is made on serology, again, tissue culture, PCR, and the treatment is with doxycycline and hydroxychloroquine. Then just briefly with the other causes of infective endocarditis, I'll just take you through some of the common causes. So Aspergillus and other non-candidal fungi, are usually associated with prosthetic valves, and we can use culture and histopathology techniques. Treatment recommendations are with amphotericin B, with surgery, of course, and then lifelong azole therapy post-surgery. Chlamydia psittaci is associated with bird exposure, particularly parrots, and we can diagnose it with serology, although there is some cross-reactivity with Bartonella. And we also can diagnose it on PCR. Treatment options include doxycycline here. The HASIC group of organisms are associated with periodontal diseases or preceding dental work. And treatment options again here, ampicillin or rocephin, we may be able to use. So in terms of Legionella is commonly associated with contaminated water distribution systems, often seen in prosthetic valve endocarditis, and we may be able to do serology, subculture onto a buffered charcoal yeast extract medium, and also PCR. In terms of the treatment options, we may use levofloxacin or clarithromycin with rifampin. So Abiotrophia and Granulositella species are quite slow and indolent, and we can grow them on supplemented culture media. Ceftriaxone is the recommended treatment option for these. Trophorema whippley, infective endocarditis may be present without any systemic symptoms. And we can diagnose this on histology, on a PAS stain, on valve cultures or PCR assay of the vegetation material. And in terms of the treatment options, rocephin or Bactrim together, or doxycycline and hydroxychloroquine is recommended as a treatment option. So the general approach to a management for culture-negative endocarditis, these are laid out by the IDSA guidelines, where again, they also recommend a good evaluation of epidemiological risk factors, taking a good history of prior infections, including cardiovascular infections, exposure to antimicrobials, the clinical course, severity, and extracardiac sites of infection of the current infection should be performed in all culture-negative endocarditis cases. They also recommend close consultation with an infectious diseases specialist to define the most appropriate antibiotic therapy in patients with CNI. For patients with acute clinical presentation of native valve infection, they recommend coverage for Staph aureus, for the beta hemolytic streptococci, and aerobic gram-negative bacilli. For subacute presentation with native valve endocarditis, coverage for Staph aureus, the viridans group, streptococci, the HASIC group, and enterococci is what's reasonable. In terms of culture-negative prosthetic valve endocarditis, coverage for staphylococci, enterococci, and aerobic gram-negative bacilli is reasonable if onset of symptoms is within a year of prosthetic valve placement. If it's more than a year, then IE is more likely to be caused by staphylococci, the viridans group of streptococci, the enterococci, and antibiotic therapy for these potential pathogens is what's recommended. If subsequent blood culture results or other laboratory methodology defines a pathogen, then obviously empiric antibiotic therapy should be revised to focus on therapy that is recommended for that specific pathogen. Then I just wanted to take you through a case that we have in the ward. Dr. Leo Chernik at Barra seems to be housing quite the cohort of culture-negative endocarditis. And this is one of his cases, actually. It's a 35-year-old female, and it's a background IV drug user. She presented with decompensated heart failure that was admitted to the CCU unit at Chris Hani Baragwanath Hospital. She was found to have quite a large tricuspid vegetation on transthoracic echocardiogram, and she was deemed culture negative at day 5. She was in CCU for quite a while, had intractable heart failure, and then was subsequently transferred to Charlotte Maxeke for cardiothoracic surgery. So she had a tricuspid valve replacement, and that tissue was sent for 16S rRNA PCR to AMPATH. And then this is the results that came back. So this was the pan-bacterial PCR. You can see the turnaround time as well that I wanted to point out. that the specimen was actually received on the 29th, and by the 3rd, we actually had a result, and Bartonella species was actually identified in this patient. So her empiric therapy was subsequently switched to doxycycline and gentamicin, and she's actually doing quite well, still in the ward currently. Okay, then we've come to the end. Our take-home messages, just wanted to go through, that we actually do have a high rate of blood culture negative endocarditis, and some of these issues that we experience, such as taking of the cultures themselves, can be mitigated. Bartonella is actually more common than we think, having accounted for about 20% in that cohort in the Cape Town study. Then a good history is always important, and that will help direct our approach to a patient with culture negative endocarditis. So taking a good epidemiological history and a history of exposure is always important. Then the fact that we do have access to serological techniques and PCR for pan-bacterial and pan-fungal. I mean, I've only come to know about this quite recently, and I think, and are we missing a lot of Bartonella and Cocciella by not being aware that we have access to these techniques? Then lastly, just as I did draw your attention to the new Duke criteria from 2023, there have been a lot of changes that were made, and hopefully, we won't be missing any more culture negative endocarditis. Okay, these are my references. Thank you.
Cool. Thanks very much, Darryl. I think for this bit, if you're able to just put on your video too. So just going to go through some of the questions that come up here. One, and you did mention it obviously, but when would you consider performing endocardial biopsy to establish histologically based diagnosis? That was one of the questions in the chat.
So if there's good reason for surgery. So, I mean, endocardial biopsy is quite an invasive procedure. So only if there's a good indication for surgery is the tissue often sent for further investigation and for PCR, histopathological analysis and further culture. Otherwise, it's not routinely done.
Okay, and then Narcissus is asking about the pan-bacterial and fungal PCRs. Can they be done directly off blood?
Yes, they can. We outsource it, like I showed you here. We outsource it to Ampath, and yes, they definitely can be done on blood.
So Darryl, the price of that's about 8,000 Rand. So it's definitely not a good thing to be doing normally. So it's also that one is off valve tissue, I think, the one you showed us, right?
Yes.
Shed surgery, yeah. So we don't usually do the PCRs directly off the blood. There are some very occasional ones which do, but usually the PCRs, the ones we've had, are focused on the valve itself, because that's obviously high yield for that. Very expensive. You mentioned earlier, we think you miss a lot of Bartonella. I think so. I think so too. The question is, how would you diagnose it? So now having seen what you've seen in terms of the data, what would you recommend to people when a patient comes in with suspicious for endocarditis in terms of initial tests, let's say?
So I think, Jeremy, taking a good history again and looking at the epidemiological risk factors would be of utmost importance, and that can help guide even empiric therapy if we deem that the patient is culture negative. Yeah.
Okay, so what tests would you do apart from blood cultures, if anything, up front? Because I guess that's the question, is really making the diagnosis. So maybe you don't, but just go.
So I think if the patient has risk factors, I think we should start with serology. So I think Cocciella, Bartonella, and Brucella serology should be something that should be done first. And then, yes, and like I said, if the patient requires surgery, then they should go for surgery. But we should start with the serology. And I think, as was proposed by that algorithm from the Western Cape, serology should be starting first, and then followed by finding other causes for endocarditis, possibly non-infective causes.
Yeah, so I guess the question is, and it's not clear, I think, in our setting, because you have to be obviously somewhat cost conscious, and also endocarditis is going to be high mortality. I guess the question is, what do you do up front? So obviously you're doing blood cultures, and the number one reason for culture negative endocarditis is people have messed up the blood cultures. And I think that's a challenge, because then it means you're probably dealing with a normal bug, not a weird bug, but you just killed it with your antibiotics because you only thought to send off blood cultures on day 3 or 4 or something like that. So I think that what you would do in that scenario might be different to what you would do when you truly have a culture negative endocarditis, when the antibiotics were taken perfectly, and then at day 5, say they're negative, all of them, and which is very uncommon for endocarditis if it's a bug that would normally grow, right? Almost all of them will be culture positive because it's literally sitting in the blood. So I think that's one of the challenges. I think when do you pull the trigger to do further tests? Do you wait for the cultures to be negative, or do you do them up front? I think, as you said, if there's a very strong risk factor for, say, let's say this person's a vet and handling, without gloves, live births and things like that, then you're going to be doing different tests than you probably would in the beginning. But mostly that's not the case, right? Mostly you don't have those sort of risk factors. So probably you wait on to day 5. Certainly for most of them, the question is about the Bartonella, because there's so much of it. It's almost no Cocciella, if you noticed, in that. I don't think, in fact, they found any, or maybe they found one. But I think the question is, what do you do? Do you put Bartonella off straight away, maybe, or do you wait the 5 days? It is a sort of subacute one. You can usually wait the 5 days, but it does make you wonder, because there is apparently so much of it, and it's certainly been everyone's experience who's worked this up, that there's a lot more Bartonella in the country than we thought. And then, as you said, what do you do next? And the next is probably serology, because you can't really PCR straight off the blood. And obviously, if they're going for surgery, then, as you rightly said, you'll catch it there, with the valve tissue, which is excellent. As you say, almost always get a result from that. It's tough though. It's difficult, because you've got to balance, the costs and the benefits. I think that one big lesson to people is to understand that, when you truly have a culture negative endocarditis, Bartonella is right up there. I mean, even if you close your eyes and they walk through the door, it looks like it's about 20% of them. So in other words, so it's massive, and that's all of them put together. Really, really, really interesting, and I think needs to be practice changing. Because one other thing is, what do you do when you're culture negative endocarditis about therapy? I don't know if you had any thoughts at that point, because it's a judgment call. So say you put the patient on standard bacterial cover for endocarditis, something like cefazolin and ceftriaxone, and let's say cephalosporin and ampicillin, or something like that. One of the combinations recommended in the ESC. What do you do if it's culture negative before you've got the results, which may take a while, right? I don't know if you had any intuitions there, because again, it's a judgment call. I think I don't think there's a clear, straightforward answer.
Yeah, Jeremy, I didn't find any new changes to that, but perhaps after this the new due criteria, maybe ESC will also change their guidelines for empiric therapy, but I haven't seen anything else. Yeah,
so one thing I would suggest is they all get a doxycycline at that point. I just think your rate of Bartonella is so high. It also covers a bunch of the other ones as well, as you know. The question of whether to add gentamicin to it before you prove it's Bartonella, I think, is harder, and I also think it's much less evidence for it. It's pretty poor quality evidence anyway. But I think that one strong consideration people should be having is to throw in doxycycline much earlier in the treatment cascade. I don't think empirically. I think most you can wait and see what grows, but at day 5, if you haven't grown anything, even if you messed up the blood cultures, it's probably still worth trying until you prove the answer. And then a very good and important question, because it's messed up a lot, is how urgently do you need to start antibiotics in a stable patient? So that's one other really important question that people, I think, get wrong a lot.
I'm not sure how to answer that, Jeremy.
Okay. So I think, as you said, it does depend on the stability. So for these really subacute ones, which have probably been going on weeks, you could wait and see what grows. It'll only be 2 days. No reason for any antibiotics. In many cases, though, it's a more acute setting. There's something which looks a bit more like it might be staph or something. Patient's very toxic and sick. In which case, you probably do need empiric antibiotics. But there's no reason ever, listen, audience, ever, to start antibiotics in endocarditis before you've done 3 sets of blood cultures, at least. You can do them 0 minutes, 20 minutes, 40 minutes, and then you can start your antibiotics 40 minutes after you've seen them, which is perfectly fine. And at least then you've got 3 sets of blood cultures that have gone off and grown. There's no reason ever to rush in with antibiotics if you suspect endocarditis, before you've done blood cultures. It's a nightmare. You showed how the mortality goes up with culture negative endocarditis, and that's mostly because they're on the wrong therapy, because no one knows what the bug is, didn't grow it. So growing the bug makes a huge difference. So the big thing is if it looks like a subacute type thing, and you could probably wait without any antibiotics. If it's very acute, you'd start antibiotics, but definitely wait for the blood cultures. Just looking through the chat quickly for others. Did you come across any role for an antibiotic hiatus with repeat cultures in a stable patient? So in other words, you would, I guess if you culture negative, but you started antibiotics before you thought of it, then you would stop antibiotics, see what grows, and then restart?
No. Not familiar with that, Leo. Okay.
Have done it on 1 or 2 occasions when it's, when we were backs against the wall. But I think, as you said, it depends on what you think the likely diagnosis is. And of course, big thing is how stable the patient is. And then there's Dr. Vader saying, just a comment, the current chlamydia psittacia antibody test contains both species and genus-specific antigens, so there may be cross-reactions with species, but not with organisms outside the species. So that's good to know. So serology should at least be able to tell you chlamydia, which is good. I'm just going through some of the other ones. Is there any data to suggest our HIV burden influences the incidence of culture-negative endocarditis?
So no, I didn't come across any data with this, to be honest.
Okay. I don't know, because most of the bugs are going to be easy to grow in normally, but obviously you're more likely to meet things like Bartonella in your socioeconomic status, who might correlate with HIV. I don't know if it's directly causal. It's a good question. My guess is that, obviously mycobacterial and things like that is different, but if you exclude the overtly HIV ones, then you're probably not going to find much difference. But I think there would still be an association given the socioeconomic difference in HIV positive versus negative overall. And then duration of antibiotic hiatus. I don't know if anyone has the answer to that. You're welcome to type in the chat. So I think it's just made up. I think you just sit there and you leave it off for a few days, a week or so, and then at most, and then you see if it's grown. But again, it's not a recommended therapy. I don't think there's much evidence to suggest it. I've only done it once or twice with very weird cases where we desperately needed the answer because there were all sorts of side effects to other medicines. Lancet also offers pan-bacterial and fungal PCR. I take it, Leanna, that's off the valve tissue mostly. You wouldn't recommend it doing straight off blood? Or I know occasionally you can still do it straight off blood, although it's very, very expensive. We'll see what Leanna says. And then I'll just post the CPT links again for the bottom there. Let me get it back. Did post it's the same link as earlier in the chat, but you're welcome if you haven't, just click on that and go there. Yes, correct. Tissue samples preferable. That's from Lancet. So again, valve tissue, I think the results are very, very good. We've done that for many years now. Blood a lot harder, a lot, and different. So again, I think this is a really nice topic in the sense that I think there's 1 or 2 big learning points, as you correctly maybe go back to your slide because you have them perfectly. Yeah. So number 1 is try and minimize. Try and minimize the rates of blood culture negative endocarditis by doing blood cultures properly, and we talked about that. So don't start the antibiotics before you've done it, and suspect it in the right settings. I think your second point is the real key take-home one, is that Bartonella is a lot more. Now we always anecdotally found that, but this Stellenbosch paper, which is fantastic. I think you've got a link to it in your next thing. So when we come to, just leave it on so people can look it up. It's a really fantastic study. It was done local and done really well. And really showed that there's huge amounts of Bartonella. So that means please send off serology. And Bartonella is usually pretty easy to diagnose with serology. So send it off at minimum at day 5, if not earlier, if you don't grow anything else. Good history, very important, agreed. And then we do have some other things. So maybe just show the link if you've got it there, Terrell, to that paper. Which one is it? Top one. Yes, yeah. That one. So do have a look there. Like I said, please do Oh, no, you've gone back.
No, that's the incorrect link, Jeremy. I'll send it
Oh, is
to
it?
you.
Okay.
I'll send it now.
Okay, we'll stick it in the chat when you've got a second. But anyway, it's really, really nice. And I think, again, lots to think about in terms of empiric decisions with antibiotics and with workup.